Welcome to Deep Dive Ortho, the show dedicated to exploring orthopedic topics with the depth and clarity you need. You're joining us for another deep dive where we unpack complex subjects, uncover surprising facts, and help you get well informed quickly. Today, we're focusing on a truly fascinating and, well, often challenging condition, Luxatio erecta. That's the inferior glenohumeral joint dislocation. Now imagine seeing only one in, 200 shoulder dislocations presenting like this. It gives you a sense of how rare it appears to be. Yet, its unique presentation and potential complications make it absolutely critical for us as medical professionals to understand thoroughly. But here's an interesting thought we'll explore. Is it really that rare? Or are we perhaps sometimes missing it because we're focusing on the final position, not the initial injury path? And joining me to navigate this intricate topic is the highly esteemed Prof. Mo Imam. It's a real pleasure to have your expertise with us today.
Thank you for having me. It's certainly a vital area for discussion, especially given that unusual presentation and, as you say, those critical considerations around its potential prevalence.
Indeed. So we'll be defining this injury, unpicking the mechanisms behind it, looking at diagnosis, and crucially, discussing the best approaches to treatment and prevention. Right, let's dive in. When we talk about Luxatio erecta, what exactly are we defining for our listeners in orthopedics and A&E?
Okay, so Luxatio erecta is quite specific. It refers to an inferior dislocation of the glenohumeral joint. The absolute classic sign is the patient presenting with their arm held rigidly, abducted, sort of fixed overhead. It's a very striking clinical picture. And as you mentioned, it is remarkably rare on paper. It accounts for only about 0.5% of all shoulder dislocations.
Yeah.
So uncommon, yes, but incredibly important to recognize quickly when you do see it.
That fixed upright arm posture, it certainly sounds pathognomonic, a real dead giveaway, wouldn't you say?
Absolutely.
I've read accounts where maybe EMS personnel have initially mistaken it for something quite different, maybe even a non-physical reaction just because it looks so odd.
Yes, that can happen. Early recognition is just so key. That unique deformity, it's a direct result of the humeral head being trapped inferior to the glenoid fossa, often sort of wedged beneath the coracoid process. And you're right, its appearance can absolutely be misleading if you haven't encountered it before.
Okay, so given it's not something you see every day, how does this injury typically occur? What are the usual high-energy mechanisms involved?
Well, it's almost invariably a high-energy injury. The primary mechanism involves a sudden, really forceful hyperabduction of the arm. This force essentially levers the proximal humerus against the acromion. Imagine someone falling, arm fully stretched out overhead, perhaps bracing for impact. Or a motorcyclist coming off their bike with an abducted arm hitting the ground first. That extreme force displaces the humeral head downwards inferiorly, and this process often tears the inferior capsule and the labrum quite significantly.
Right, so it's not just the position, it's the force driving it into that position. Now, we know the shoulder is the most mobile joint and therefore the most commonly dislocated one generally, but this specific type is rare. Can you walk us through the anatomy a bit? What makes the shoulder vulnerable in this specific way, and what structures typically bear the brunt in Luxatio erecta?
Certainly. The glenohumeral joint is, well, famously built for mobility, sometimes at the expense of inherent stability. You've got that shallow glenoid cavity covering only about a quarter of the humeral head. So stability really relies heavily on both static and dynamic stabilizers.
Okay, so the static ones first, the ligaments and capsule.
Exactly. The static stabilizers include the glenoid labrum, the joint capsule itself, and crucially, the glenohumeral ligaments. Now, while you have the superior and middle ligaments playing their roles at different abduction angles, for Luxatio erecta, the really key structure, the one that takes the hit, is the inferior glenohumeral ligament complex, the IGHL.
Ah, the IGHL.
Yes. Its anterior band, specifically, is the primary restraint against that anterior and inferior translation when the arm is up at 90 degrees abduction and externally rotated like in throwing, or the mechanism we just discussed. So Luxatio erecta almost always involves significant tearing of these static structures, particularly that inferior capsule labrum complex.
Makes sense. And the dynamic stabilizers the muscles, how do they fit in?
Right. The dynamic ones, your rotator cuff muscles, the deltoid biceps brachii, they also play a crucial role in centering the humeral head. But with the kind of high energy involved in Luxatio erecta, these dynamic stabilizers are often simply overwhelmed. The force leads to that significant tearing of the inferior capsule and labrum we mentioned, which then permits the humeral head to escape downwards.
Okay, so we've got the what and the how. Let's move to diagnosis, spotting it. Beyond that very obvious arm position, what should clinicians be laser focused on and what imaging is non-negotiable?
Diagnosis starts, as always, with a detailed history. How did it happen? And then observing that characteristic fixed, abducted, overhead arm. But the physical examination, this is where things get really critical. A comprehensive neurovascular assessment is absolutely paramount. I mean, before and after any attempt at reduction.
Can't stress that enough, can you?
Absolutely not. You need to check radial and brachial pulses meticulously. Assess the axillary nerve function, that's shoulder abduction, sensation over the deltoid patch, and check all distal neurological function thoroughly, because Luxatio Erecta carries the highest incidence of neurovascular injuries among all types of shoulder dislocations. It's a really important point.
What sort of figures are we talking about?
Well, neurologic injury, things like brachial plexopathy, or most commonly an axillary nerve neuropraxia, can occur in up to, believe it or not, 60% of cases.
60%? Wow.
Yes. And vascular injury, particularly to the axillary artery, can be seen in up to nearly 40%, around 39% of cases in some series. These are not insignificant numbers at all.
They really aren't. Staggering, actually. So that pre-reduction check is vital baseline information. What about imaging?
Imaging starts with plain radiographs. They're the initial go-to. Essential views are the true antero-posterior, the Grashy view, and an axillary view. Although getting an axillary view can be challenging with the arm locked up like that.
Understandable.
These x-rays will clearly show the humeral head sitting inferior to the glenoid, and typically the shaft of the humerus running parallel to the scapular spine. That picture is pathognomonic.
And post-reduction.
Post-reduction, an MRI is really essential. It should be obtained after the shoulder is back in joint. MRI is the gold standard for evaluating all those associated soft tissue injuries we've talked about. Rotator cuff tears, which are extremely common, even in younger patients, glenoid labrum tears, injuries to the IGHL bands. MRI picks these up, plus any subtle bony injuries too.
So the dramatic presentation is often just the tip of the iceberg. High likelihood of significant underlying damage. That really underscores needing a full workup after getting it back in.
Indeed. And this loops back to that point about prevalence we touched on earlier. Many patients who initially sustain an inferior dislocation might actually present to A&E after it's spontaneously or partially reduced into a different position, maybe an anterior dislocation.
Ah, I see.
So they get diagnosed with, say, an anterior dislocation, but the initial event, the path the humerus took, was inferior. This suggests the actual incidence of Luxatio Erecta as the initial injury mechanism might be higher than that 0.5% figure suggests. Understanding the dislocation path is arguably as important as the final position we see.
That's a fascinating point. The journey matters as much as the destination. Right, so once it is diagnosed, what's the treatment pathway from getting it reduced to long-term recovery?
Okay, treatment primarily involves getting the joint back in place, closed reduction, followed by a structured rehabilitation program. The key with closed reduction is doing it gently and controlled, given that very high risk of causing or worsening neurovascular injury.
Makes sense. What techniques are commonly used?
Well, countertraction is one approach, similar in principle to reducing an anterior dislocation. You apply those steady traction to the arm, while someone provides countertraction, perhaps with a sheet across the chest. Another very effective method is the two-step technique.
How does that work?
The idea here is to first convert the inferior dislocation into an anterior one. The clinician might push laterally on the upper humerus while pulling upwards, superiorly on the elbow, effectively rotating the humeral head from its inferior position around to an anterior one. Once you've converted it to an anterior dislocation, you can then use any standard anterior reduction technique you're comfortable with.
Clever. Okay, so you've successfully reduced it. What next?
Post-reduction, the arm is typically immobilized in a sling, usually for around 1 to 3 weeks, just to allow that initial soft tissue inflammation to settle and healing to begin. Pain management is obviously crucial during this acute phase as well.
And then rehab starts.
Yes. Once the immobilization period ends, a structured, progressive rehabilitation program is essential to restore strength, flexibility, and range of motion. It usually progresses in phases. Phase 1 might be during immobilization, focusing on isometric contractions. Phase 2 involves gradually increasing range of motion, carefully, often with specific limits on things like external rotation initially. Then Phase 3 aims for full active range of motion, introducing resistance exercises and eventually plyometric training for athletes.
Is surgery often needed?
Operative treatment, so surgical repair, is definitely indicated for certain groups. Active younger patients often benefit from repair, especially if they want to return to high-demand activities. And it's certainly indicated when there's significant capsulabral damage seen on the MRI or a traumatic rotator cuff tear. In fact, Prompt surgical repair for acute rotator cuff tears sustained during the dislocation is often recommended to prevent the tear retracting and potentially becoming irreparable later on.
And arthroscopy is usually the way to go.
Yes, arthroscopic approaches are generally preferred. They allow for a thorough assessment of the joint and let you address multiple issues simultaneously repairing the labrum, the capsule, the cuff, all through minimally invasive techniques.
Right. A very careful, staged approach tailored to the patient and exactly what structures were damaged. Now, given the high energy and potential for damage, what are the most common complications we need to be vigilant for, and what advice can we give patients about prevention?
Complications, as we've touched upon, can be significant. Those neurovascular injuries are top of the list. Axillary nerve palsy is the most common nerve injury, thankfully. It often recovers once the pressure is off post-reduction. But brachial plexus injuries can also occur. And that risk of axillary artery injury, potentially thrombosis, is a major concern requiring immediate attention if suspected. Again, that thorough pre- and post-reduction neurovascular exam is absolutely non-negotiable.
Okay, besides neurovascular.
Rotator cuff tears. Very common, as we said, even in younger patients, but particularly prevalent in older individuals, hence the importance of that post-reduction MRI to identify them. Bony injuries are also possible. Fractures of the greater tuberosity or the glenoid rim can happen during the dislocation or even during reduction if not done carefully. And then there's recurrence. This is actually one of the most frequent long-term complications, especially in younger active patients. Some studies report recurrence rates exceeding 70% after initial treatment.
70%. That's incredibly high. It really highlights the need for good rehab and maybe considering surgery in the right patients.
Precisely.
So, looking beyond managing the acute injury, how can we help patients prevent this happening again or even happening in the first place?
Prevention really requires a multifaceted approach. Firstly, education and awareness are key. Especially for athletes or people in contact sports, understanding the mechanisms that cause it, learning to avoid those extreme hyperabduction positions is crucial.
Makes sense. What else?
Secondly, strengthening and conditioning. Comprehensive programs that target the rotator cuff muscles and the scapular stabilizers really enhance the shoulder's dynamic stability. Isotonic strengthening, interval sport-specific programs, these can be very beneficial. Thirdly, technique modification. For athletes, this might mean specific coaching on proper falling techniques, how to tackle safely or how to catch, to avoid putting the arm into that vulnerable extreme position.
And finally,
Appropriate equipment use. For some sports, protective gear like well-fitting shoulder pads or perhaps specific braces might provide some additional support during high-risk activities.
so it's a combination of recognizing the injury acutely, managing it meticulously, and then really empowering patients with the knowledge and tools to minimize future risk. What an incredibly insightful deep dive into Luxatio Erecta. It's crystal clear that while it might present rarely, its distinct appearance and that high risk of neurovascular and major soft tissue complications make it an injury demanding immediate expert attention. The importance of that meticulous diagnostic pathway, the careful reduction, and especially that post-reduction imaging, well, it simply cannot be overstated. If you found this deep dive valuable, please do consider rating and sharing Deep Dive Ortho with your colleagues. It truly helps us reach more healthcare professionals like you. And just as we conclude, it does prompt a broader thought, doesn't it? Building on that idea of the dislocation path, how many shoulder injuries might we be missing or perhaps misclassifying if we only focus on the final position the patient presents in, rather than considering the entire mechanism and the initial path the joint took? Something perhaps to mull over until our next deep dive. Thank you so much for sharing your invaluable expertise today.
My pleasure. Thank you for the discussion.
And thank you for joining us on Deep Dive Ortho. Until next time, keep learning and stay well informed.